You're on mute, David.
Good evening. My name is Maura, and I am the Student Engagement Officer at AfOx. I am delighted to welcome you all to this month's digital insaka. Many thanks for joining from wherever it is that you are joining us from in the world. Today, the first talk asks whether human resources for health in South Africa represent a window of opportunity for investment and reforms. South Africa continues to experience significant human resources for health challenges despite higher national health worker densities than most other African countries, and demonstrable progress in HRH since democracy in 1994. The country's human resources for health crisis is characterized by the maldistribution of health workers, lack of consolidated national health workforce accounts data, fragmented HRH information systems, resource constraints, and insufficient government capacity to guide health workforce planning and strategic management. In South Africa, as elsewhere, the COVID-19 pandemic has underscored the criticality of HRH while exposing the fault lines of underinvestment and insufficient prioritization of health workers. This talk will provide a brief analysis of HRH in South Africa and present select findings from a novel longitudinal study called Wisdom. The study tracks the career choices and job location decisions of 8 groups of health professional graduates of the University of the Witwatersrand in South Africa. The talk will conclude with making the case for using COVID-19 pandemic as a window of opportunity for strategic investment in and reforms of health resources for health in South Africa, with lessons for other low and middle income countries. Our next talk today reflects on MRI research and education in Africa. Investments in MRI technology have altered modern healthcare delivery systems. Despite having the world's highest incidence of non-communicable diseases, African countries have limited access to MRI technology and a critical shortage of competent MRI experts and technicians. There have been some sporadic MRI training and research programs in the region, but they have been mainly uncoordinated, underfunded, and without clear outcomes or benefits to the region. The Consortium for Advancement of MRI Education and Research in Africa, the acronym of which is CAMERA, is an African MRI professional network with global partners dedicated to developing a long-term MRI training and mentorship program in Africa. Our mission is to form partnerships and strengthen existing relationships in order to help underrepresented MRI researchers in Africa get the skills they need to conduct MRI research, innovate, and utilize MRI technology to enhance Africa's healthcare systems. The speaker, who I will introduce in a minute, will briefly outline CAMERA's vision, challenges, accomplishments, and future plans in its efforts to gain a seat for Africa at today's imaging research table. Our first speaker today is Professor Laetitia Rispel. Laetitia is a professor of public health and DST NRF research chair. She was the head of the School of Public Health at the University of the Witwatersrand in Johannesburg. Her research expertise is in public health, specifically health policy and systems research. She has published extensively in this field. Laetitia has more than 20 years combined experience of research, teaching, public health, executive management, and health leadership. And our second speaker for today's insaka is Associate Professor Godwin Ogbole. Godwin teaches at the University of Ibadan in Nigeria, as well as teaching diagnostic neuroradiology to medical students. He works as a consultant neuroradiologist at the affiliated University College Hospital, Ibadan. In terms of research, his major interests are stroke, dementia, and pediatric epilepsy. He is also keen on improving the quality of brain imaging research in Africa, and more recently has become fascinated by applying machine learning tools to his work. Just to remind you that each speaker today will give a 15-minute talk in succession. The Q&A will take place after both talks have been delivered. Please remember to post your questions in the chat box on YouTube. If you prefer to submit your questions anonymously, you can use the Slido option. The code for Slido for today's talk is 104249. The Slido link should have now been popped into the chat box by one of my colleagues. First up, Laetitia, whose talk is titled Human Resources for Health and COVID-19 in South Africa, Window of Opportunity for Investment and Reforms. Welcome, Laetitia.
Thank you. Thank you very much, Moratehi, for that kind introduction, and good evening to everyone. And I guess for some people in the East, it might be midday. So thank you very much for joining us. What I hope to do in the next few minutes, firstly, I want to acknowledge the fellow senior Africa Oxford Fellows. The red dots represent the countries that we're from. So all of them are already in Oxford, and I'm sitting on the 3rd floor of the School of Public Health building in Johannesburg, South Africa. So what I hope to do is to give a very brief background and context, then hone in on COVID-19 and human resources for health in South Africa. I'm going to give you some sound bites from the Wisdom study, particularly the experiences of young health professionals during COVID-19. And then I'm going to conclude my talk with a proposition on the opportunity presented by the COVID-19 pandemic. So just very briefly, in terms of the global context, many of you might be familiar with these two seminal documents that were published in 2016, the Global Strategy on Human Resources for Health and the Working for Health and Growth, the report of the High-Level Commission on Health, Employment and Economic Growth. In 2018, there were 3 global reports on quality produced, but in essence, what all of them had in common is that firstly, human resources for health are an investment, and secondly, human resources for health are the heartbeat of quality universal health coverage. It's well known that we have a global human resources for health crisis. The Commission report estimates that there are a shortage of around 18 million health workers, most of them, the majority in low and middle income countries, with an estimated 4.2 million alone needed in Africa. Of course, Moratehi talked a little bit about the COVID-19 pandemic, but estimates suggest by the World Health Organization that more than 100,000 health workers died as a result of COVID, and this, of course, has exacerbated the crisis that we already have. In terms of South Africa, just a very brief overview. South Africa is a constitutional democracy. We have many progressive laws that have been passed since 1994, a mixed public-private healthcare system with a private health sector that accounts for roughly 50% of expenditure, but only provides care to around 17% of the population. South Africa is known for its excellent human resources for health education and training. The regulation of health professions is well established. It has, as was said in the abstract, much better national health worker densities compared to the majority of other African countries, and there are relatively high salaries in the public health sector. If you ask people from exactly how many health workers we have, nobody will be able to give you the figure because we don't have that information available. The graph or the table that I'm showing you shows the number of health professionals that are registered with the various councils. And as you can see in the case of medical doctors, around 44,000, and nurses make up the bulk. All categories of nurses constitute about more than 200,000 that are registered with the South African Nursing Council. If we look at the skills mix in the public health sector in 2019, again, you can see the numerical dominance of nurses making up roughly 56% of all public health, direct healthcare providers, doctors 9%, and community health workers around 22%. If we hone in a bit on the challenges and contestations, firstly, there's a disjuncture between human resources for health and health or health system outcomes. So we should be doing much better in terms of health outcomes if we look at the resources that we have available. But South Africa has a very complex quadruple burden of disease. Health workforce planning is hampered by inadequate national capacity and skills, lack of appropriate and credible planning models, and an absence of national health workforce accounts data, which makes it both in the public and private health sectors, which compromises the ability to have both good estimates, valid estimates of availability, and of course it also impacts on our ability to establish needs. There remain huge inequities between the public and private health sectors in South Africa. This just gives you an idea. Overall, the national density of medical specialists of all types, it's around 16.4 per 100,000. However, when we look at the number of medical specialists in the public sector, it's estimated to be around 7 specialists per 100,000 population compared to 69 in the private health sector. However, these inequities are also replicated in the public health sector, with the rural provinces experiencing significantly lower densities compared to the more urban provinces. These inequalities are most marked for medical specialists, nurses, and community health workers. So, for example, in the Western Cape province, which is an urban province, we have around 25.8 medical specialists per 100,000 public sector population, whereas in Limpopo, it's only 1.4 per 100,000. So as you can see, it's extremely difficult for somebody in the rural province of Limpopo to have access to skilled or to highly specialized medical practitioners. Now, so I was the chair of the ministerial task team that developed the 2030 Human Resources for Health strategy. We use 3 models, and all the models that we use suggest that there's both a current and projected shortage of skilled health professionals in South Africa. One of my arguments is that the crisis of leadership management and governance is at the core of these human resource challenges and contestations that we have in the country. Of course, in the case of the COVID-19 pandemic, it's both underscored the criticality of human resources for health, and it's also exposed the chronic underinvestment and vulnerabilities of human resources for health. And earlier this year, the National Institute of Occupational Health published a report with an estimated 1,233 health workers who died during or as a result of the COVID-19 pandemic, which is roughly a case fatality rate of 12.5%. Now, if we assume that each health worker who died had on average experience of about 10 years, it translates into more than 12,000 person years of experience that's lost. But we also know that the average age of these health professionals who died were in their mid-50s. And so, of course, even the number of person years of experience that's lost, that's an underestimate. I'm now going to move to the wisdom study, which was actually what got David Kerr interested in the first place to ask me to do this talk. So very briefly, wisdom is a longitudinal study. It's an acronym which has a very long name that stands for Wits Longitudinal Study to determine the operation of the labor market among its health professional graduates. Wisdom tracks 8 groups of health professionals, clinical associates that are also called medical assistants in other African countries, dentists, doctors, nurses, oral hygienists, occupational therapists, pharmacists, and physiotherapists. The 2 primary aims of wisdom, firstly, is to examine the career choices and job location decisions of Wits health professional graduates over a period of 15 years. And then secondly, it's to generate new knowledge and evidence on health workforce dynamics in the country. So the baseline study was done in 2017. That's when the cohort started, and every year we do a survey, self-administered. That's sent. The link is sent to them, and I'm going to report on the results of the survey from 2020, which, as you know, was the start of the pandemic. So roughly 336 cohort members were working at the time of the 2020 survey. 7.4% indicated that they experienced symptoms, but these weren't confined by a test. In addition, another 14.9% of them tested positive for the virus. And this slide just gives you an idea. You can see the occupational therapist had the highest proportion testing positive, of 30.4%, nurses around 22.2%, and doctors 15.0%. We asked them a series of questions. I'm just going to share with you, because of time constraints, I'm going to share with you a couple of the slides. We asked about personal protective equipment, which, as you know, certainly a lot of emphasis had been placed on personal protective equipment. This slide gives you the proportion. So we asked the question in the negative, which was, I did not always have protective equipment when needed. And we would have expected them to disagree with the statement. And as you can see, 55.4% agreed that they didn't have personal protective equipment. So that implies that's of the overall cohort. And you can see the range for medics, 76.5%. Nurses 44.4%, and that's obviously an indictment on our health system, particularly in relation to the protection of young health professionals. The second piece of information that I want to share with you is we asked them also a statement which said, I felt more stressed at work than before the lockdown. And as you can see, for the cohort as a whole, 70.2% agreed with that statement. I can't tell you why the occupational therapist felt so stressed out, because as you can see, 95.7% of them agreed with that statement. For medics, it was 70.6%, nurses 60.7%, and I'm just highlighting this because these are the direct providers of care. So in conclusion, the COVID-19 pandemic has really underscored the unfinished agenda, firstly, of inequities. Of course, I'm talking specifically about South Africa, but I think this also applies to many other African countries. And in fact, many countries, I think there's even relevance in the UK. Firstly, it's underscored the unfinished agenda of inequities in the distribution of human resources for health, the unfinished agenda of really protection and caring for health workers on the front line in terms of providing positive practice environments and taking care of their mental health. And thirdly, it's also performance of the health workforce. And this is my last bit, Moratehi, is that the COVID-19 pandemic, I think, provides a window of opportunity, firstly, for investment in human resources for health, and for introducing key reforms that focus on the entire health system in the case of South Africa, and that also makes provision for robust human resources for health information systems. I just want to acknowledge David, and thanks to all of you again. Thank you.
Thank you so much, Laetitia. That was a fascinating talk, and thank you for highlighting the challenges in human resources for health, and I hope it gets people thinking about what we could do, especially in South Africa, in the future about this issue. We are looking forward to the Q&A. We've already got some questions for Laetitia, but please remember to continue to submit your questions using the chat box or the Slido link. We will now move on to Godwin, whose talk is titled Strengthening MRI Research and Education in Africa, Innovations and Partnerships. Thank you, Godwin.
Thank you, Maura. Thank you very much. I'll be discussing this afternoon or wherever you are in the world about strengthening MRI research and education in Africa. I'm going to be talking about innovations and partnership. Well, I have no financial interest or relationships to declare. Just a minute. Okay. So, Africa, the past, the present, and the future. By the end of this talk, I expect that everyone would have learned something about Africa, at least two things. One of it is that the oldest university in the world is in Africa, and this can be found in Fez, Morocco. It was founded in around 859, and it was started in a mosque. Also to say that Africa is the most genetically diverse continent. Africa also is the second largest and the most populous continent in the world, and hosting about 17% of the world's population. It has abundant mineral resources and also home to 25% of global disease burden. Africa is poor and underdeveloped. Africa also, by 2050, will host at least one of every inhabitant in the world will be an African. And 40% of the world's under 18 population will be in Africa. So the working force of Africa will be, the working force of the world will be in Africa. So these are the things you need to know. I will start my talk by giving you a short story, and I will tell you about global MRI technology. I will tell you about the challenges of MRI research in Africa. I will ask 5 questions, and I'll also try to answer these 5 questions, and then summarize the answers, and then recognize those who have been supporting our research here in Oxford, also and around the world. Okay, to my story. This is Ekiti State. It's a very hilly state in the southwestern part of Nigeria. About 18 years ago, a mathematician woke up in the early hours of the morning and found out that he could not move some part of his limbs. Later, he discovered that he could not talk. He was taken to the hospital, and he discovered that he had a stroke. A stroke is an accident in the brain. An accident has happened in the brain, that the blood vessel, so there was some disruption in the blood vessels. The doctors managed him conservatively, and then he went unconscious and then recovered from his unconsciousness. But after a few days, he became unconscious again. And the doctors have no way of managing him. He had to travel, he had to be taken by an ambulance to about 250 kilometers away to Ibadan for him to have an imaging of the brain so that they could find what was wrong with his brain. Unfortunately, that mathematician did not make it. He had a stroke. What is stroke? Like I said, stroke is a vascular accident that happens in the brain. It is a global problem, and it is a leading cause of death in Africa. Every minute, 6 Africans get a stroke, and 40% of those Africans will die within a month of having that stroke. And the stroke in Africa affects the young population, usually about 45 to 60. It causes a huge social and economic burden, and can only be diagnosed if you have some form of imaging. There are 2 kinds of imaging that you can have for stroke. It's either you do a CT or you do an MRI. There is no clinical way of determining the type of stroke an individual has without any form of imaging. So without imaging, the doctors are just gambling, and they use their clinical acumen, and hopefully, if by way of luck, the patient survive. But imaging is a standard way of identifying the type of stroke an individual has, because each type of stroke is different. Each management for each type of stroke is also different. If you treat one for the other, you put the patient at risk. So imaging has a big place in the evaluation of patients with stroke. Let's talk about MRI. MRI is a device, is a medical device, and it is used for looking at inside of the body to be able to help doctors to make decisions and to treat patients appropriately. It has advanced since it has changed the face of medical diagnosis. And since its introduction in the 80s, it has progressively increased and has altered modern medical healthcare. These days, you have what? You have faster systems that produce very high quality scans, and they can also have simplified cardiac and lung imaging. I was reading a book recently, written by Tony Stocker, and he said, given the speed of MRI method development of the advanced protocols that are being developed today, will be outdated in the near future. And he has said also that 7 Tesla, which is the magnetic field that is usually used to generate the images, which is currently not used, just currently for research now, that in a few years, it will be the standard practice. All this technology is not available in Africa. Africa houses most of the non-communicable diseases, and it is yet the place where you do not have these devices that can address these problems. MRI is a technology that can usually be used to what? Help in oncology, help you even in trauma cases, help you with stroke, help you with cardiac, lung problems and all that. But Africa today does not have access. It has limited access to the MRI technology. It has limited access to research funding, and even few are competent to handle these machines. And there is no coordinated training programs in Africa. Africa is behind in terms of MRI technology that has changed the face of modern imaging and modern healthcare. If you look at this graph, it shows that 70% of the world's population have minimal or zero access to MRI. And 50% of these people, of these countries, or this population are in Africa. Africa is behind in this technology. This technology is changing healthcare system, is improving health outcomes in other parts of the world, but is not readily available to Africans, and even for Africans to do research and provide even new technology. One of my friends, Bruce Obiageli, also made a comment. He said, it is increasingly recognized that while there is still a lot to understand, there needs to be a major shift from incessantly studying the problem to developing interventions to resolve it. Africa has been studied, has been overstudied. And today, the Consortium for Advancement of MRI Education and Research, this is CAMERA, a group of professional specialists coming together and partnering with global partners, have come together to see how they can resolve this problem of making this technology available. CAMERA is a product of the European Society of Magnetic Resonance in Medicine and Biology. And the mission of CAMERA is to what? Is to establish partnerships, to strengthen existing relationships and collaborations that have come into Africa and are willing to help Africa. It also plans to support underrepresented MRI researchers in Africa and provide educational resources for clinical MRI research in Africa and drive innovation using technology to enhance Africa's healthcare systems. I will tell you more about CAMERA by asking 5 questions and trying to answer them. One of the questions I will ask is, why would you want to strengthen MRI education? These are the questions we have asked. Why not strengthen other tools of managing patients? I'll answer that question. But the other question is, what are the challenges of MRI research and practice? How do we plan to achieve this? And also, who are our partners? And then finally, I will tell you about when this initiative started. Why do we want to strengthen MRI education in Nigeria? We have recognized that MRI is the future of imaging in medicine, especially in neuroscience, where you need to look at the brain, where you need to study the brain. And we know that there is an epidemiologic transition in Africa, that we're going to have more people that are going to live longer, they're going to have brain diseases, and also there is no way of studying the brain without looking at inside the brain. You can have a heart transplant, you cannot replace the brain. You can have a lung transplant, you can have a kidney transplant, but you cannot have a head transplant. So there is a need to fully utilize the technology to study the brain and to be able to help our patients live longer. We also need to be able to communicate with other consortia around the world. We need to also have the same capacity, educational capacity, to be able to relate to people and improve the quality of education in Africa. The human capacity, the people who know about MRI, who can use MRI, the devices, the medical physicists, the radiographers, the radiologists, are insufficient in Africa. The equipment that we need to use to manage, to treat, and to evaluate patients are also deficient in Africa. The distribution of MRI in Africa is also unbalanced. Most of the MRI in Africa is concentrated in the urban areas where only the rich have access to. And government is not recognizing the problem. And government is not funding MRI research, is not funding neuroscience research. This is why we need to strengthen education in Africa. What are the challenges of MRI research and practice? One of it is funding, infrastructure, and education, and then the institutions. MRIs, funding for neuroscience, we have seen, based on a study by Mena et al., looking at publications over 20 years of neuroscience in Africa. He's found that, look, that domestic contributions of nations was weak in Africa. And most of the resources, most of the things that were done in Africa were funded by international agencies. That if you compare with other countries, you'll see that what? That in the UK, they give more of domestic funding is done for neuroscience research. Most of the people that fund research in Africa are the European countries and North America. And the greatest funders of research in Africa are the NIH and the Wellcome Trust. So there need to be what? More local funding for research in Africa. The richest countries in Africa, Nigeria and South Africa, what do? They spend little of their money on healthcare. The WHO recommends that you should have at least 10% of your GDP on health. South Africa is doing great, at least it spends about 9%, but you can look at Nigeria. Nigeria spends the least in Africa on healthcare. And also the physician per person population is also the lowest in Nigeria. And this is similar around other African countries. So there needs to be a change in this dimension. Also infrastructure. Africa has weak infrastructure. Electricity supply in Africa is weak. There are no facilities for equipment maintenance. The equipment vendors also are not available in Africa. They do not have place in Africa. Most of the vendors, they don't produce their machines. They just bring it in and give it to people to use. They are not developed in Africa. There are no workers. The technical expertise is low. Jobs are low for such technical jobs, and there are no innovations. All these are done from outside Africa. So there needs to be what? An inside working off these technologies in Africa. If we are able to do this, then research will be reversed. The MRI density in Africa is very low. Most African countries have less than 1 MRI per 1 million population. The number is very, very small compared to other parts of the world. Africa, the country that has the highest number of MRIs is in Libya, compared to places like Japan, where they have like 55 MRI scans to 1. In Nigeria, you have less than 1 to at least 10 million population. So for infrastructure, most of the equipment we have are donated. In Uganda, they realized that most of their donated equipment were not functional. They couldn't use them after 2 years. And when they were spoiled, there were no ways of maintaining them. Most equipment in Africa have long downtime because you have to wait for somebody to come from either the West to fix this equipment. These are the challenges we have. Regarding education, most of the experts that are developed in Africa leave Africa. This is a challenge. And those scientists in Africa have no pure or good career pathway to advance their research in Africa. The brain drain is massive in Africa, and we have to find ways to reverse this. How do we plan to overcome these barriers? Camera is trying to form partnerships and network with global institutions and find ways of which they can get the vendors to take a look at Africa, see ways we can develop machines that can work with Africa. And we are partnering with, at least the University of Oxford. We're also partnering with the University College London to see how we can improve the quality of imaging in Africa using the low field systems, which can work within Africa, because most of the high field systems, since they're expensive, they're not available to most Africans. So we are finding ways of which we can develop systems that can work in Africa. Also through Camera, we're looking at doing advocacy work to see how we can improve the quality of funding for research in Africa. These are the members of the steering committee for Camera, which is led by Uduna and Nazado. These are experts from around the world working together to improve the quality of care in Africa. The goals of Camera are what? To seek and train young MRI scientists, establish MRI chapter of the International Society of Magnetic Resonance in Medicine in Africa, build mentorship programs that can collaborate with researchers around the world to engage in research projects that can change the dynamics of healthcare in Africa. We also plan to develop an MRI online resource where people can access these facilities, an open source that people anywhere in the world can have access to and use that technology to cause innovation and change in their environment. Camera is at the forefront of innovation. One of our members, Jones Obungolok, is also building MRI systems in Uganda. He's working with Andrew Webb, who is a professor of radiology in the Netherlands. And he has said, and he's working on developing portable MRI systems that are low field, low cost, but accessible and have clinical impact and can be sustainable. His goal is that he wants to develop MRI machines that cost 1% of the current MRI scanners. And they're also working with the Bill and Melinda Gates Foundation and also a private company that is building portable systems that can be available to the rural population at affordable cost and also produce equal clinical impact as the big scanners around the West. So the thing about Camera is bringing all these bodies together to provide change and impact change in Africa. Who are funding all this? So we recently got a 3-year funding from the Chan Zuckerberg Initiative to be able to build this network in Africa. And Mark Zuckerberg says, we believe all lives have equal value. And that includes the many people who will live in future generations than live today. Our society has an obligation to invest now to improve the lives of all those coming to this world, not just those already here. So he's the one providing the funding. And these are some members of the initiative. This initiative started in 2009 and is taking off fully this year to provide some form of improvement in the MRI education in Africa. What are our expectations? We believe we want to create an enabling research environment in Africa, advance MRI education, train and retain specialists in Africa, maintain our vision and our collaborations, empower African researchers around the world, and also recruit talented and diverse mentors who can work with Africans to democratize MRI within Africa. What are our accomplishments? We've been able to build or assemble a diverse team of global scientists, and we've hosted an MRI workshop. We have also been able to conduct an MRI survey around Africa that gives us a better picture of how to intervene. Recently, very soon, we also got permission to host a symposium at the International Society of Magnetic Resonance in Medicine, which will be holding this year. And we have been initiating collaborative talks with members of industry and several universities around the world. Now, finally, to Ekiti. The mathematician I told you about is Matthew Ale. He was my father-in-law, and I want to dedicate this talk to him. He died of stroke. He was the one who left Ekiti to Ibadan to get an MRI scan, but could not make it. I want to make his soul rest in peace. So in summarizing, Africa should make concerted effort to gain a seat at the table of current and future MRI research. Africa should also collaborate, adapt, and innovate and translate technology to meet its needs. Africa must avoid relying on handouts. This is the future. We need to walk into the future with others and not stand back. So these are people I want to acknowledge. I have several collaborators. I want to appreciate everybody. Thank you so much for your support. You are all appreciated. Thank you.
Thank you so much, Godwin, for your presentation, and the work that Camera is doing is really fantastic. And I think it is true that we tend to focus a lot on the challenges and maybe not spend enough time on the solutions. However, before we go on to talk about the work that Camera is doing, I'd like you to talk a little bit more, Godwin, about some of the challenges that you've elaborated on. We've gotten a question here about, is there capacity for MRI manufacture in Africa? And the person's thinking particularly about Egypt and South Africa. And if there is not, what are the barriers to manufacturing in Africa? And to add to that, a second part of the question is, to what extent do you think that the MRI problem shares similarities with what we've seen recently in terms of vaccine access problem in Africa, and viewing it as a political problem, and how we would be able to kind of manage that as Africans who are looking for solutions?
Thank you very much for that question. Like you said, putting it alongside the vaccine problem, the greatest problem Africa has is infrastructure. And That is why we're talking about innovation. The thing regarding vaccine is similar to what we're dealing with, is that the world is looking at Africa as a place where you can donate equipment, donate tools, donate things to. And that's what they're doing with the vaccines. And Africa is asking that, look, don't give us the vaccines, give us the technology to be able to make these vaccines and take care of our people. And this is similar to what we are saying with MRI, with the technology. This technology is available. Help us to develop our own systems. Help us to be able to build similar systems. We know we have infrastructural problem, and this is what Andrew Webb is doing. Right? You're able to build systems that can survive in Africa, systems that require low power. This infrastructure are not fully in place, but places like South Africa have been able to develop systems, and they have a research system which they are using. You know, if it can work in South Africa, we are saying that these things can also work in other parts of Africa. Help us to build this system, help us to develop our capacity to produce these machines to help our people.
Thank you, Godwin. I think I'll bring Laetitia back into the conversation. I think in both talks, these are quite big problems, systems problems that affect many different parts of society. And so for Laetitia, someone's asked, how does racial and social inequality in South Africa affect the distribution of health workers across the country?
Sorry, thank you very much for that question. Of course, in the country like South Africa, you know, race always intersects with these the problems that I've highlighted. You know, so those, for example, the face of poverty in South Africa continues to be a rural Black African women. And so, I mean, I didn't talk a lot about it because obviously in a 15-minute talk, it's very difficult to highlight all of these, you know, inequities. There also remain inequities, for example, if you have to break down the health professionals by race, you know, then certainly people of color remain underrepresented, especially in kind of top positions, as well as in the very senior, you know, very senior positions. Because it takes a long time, you know, for example, to get to the position of head of department. There's been a lot of progress, but yes, race remains very much part and parcel of the challenges in South Africa.
So we've got two questions here that I think kind of focus on what we could do about these challenges. And the first one is, what robust strategic interventions do you think would be highly needed to bridge the healthcare divide in sub-Saharan Africa, especially in South Africa? And the second question is, what is the most immediate area for workforce investment in South Africa? And what would it take to mobilize and support this?
Well, I mean, those questions in a way are related. And what struck me when Godwin was talking, I mean, he talked about the problem of infrastructure, but I mean, I would challenge him. For example, I would say that I think more than infrastructure, sorry, Morateki, the lights in my office work with a sensor, so I have to get up just so that the lights go on again. You can see me. Sorry about that. So I mean, I would say the overall, the critical issue is really one of what I've said at the core, where there's a crisis around, you know, MRI, where there's a crisis about access to healthcare, about vaccination. It's a crisis of leadership, management, and governance, and that's what we have to address. So if I had a magic wand, I would strengthen the National Department of Health in South Africa. I would, for the first thing I would do would be to create the political will to create a very high level technical unit that's kind of like, and I would employ suitably qualified individuals who are able, not necessarily would try and do everything themselves, because they can draw on partners and on resources in the universities. People with a vision that actually understand the importance of investing in the health workforce. That's the number one thing I would do if I had a magic, wand, and then everything else will actually fall into place.
Thank you, Laetitia. I think on that note, I would like to invite kind of Godwin to give remarks on what role you think leadership and management and governance plays, and whether Camera kind of has a look on addressing those issues in MRI access and education and training.
Well, thank you, Maura. These are very, very, shall I say, heavy questions. Leadership plays a role in everything. And I think it's that the problem of Africa has been leadership. Africa has resources. Africa, even though it looks poorest, because it's poorest in economic strength, but it's the richest in natural resources. We are rich, but our resources are not properly managed. So governance, leadership is the problem. So for Africa, if we're going to make a change, we have to look for ways of changing our leaders. But now, since we cannot change our leaders automatically, like nobody has a magic wand, so what do? We have to find alternative ways. And that's what Camera is trying to do. We find ways to innovate, to look for ways which we can use simple things to address health problems. MRI, the machine itself, the original machine, the original MRI, the bigger the machine, the better the quality of the imaging. But can we as Africans, since we cannot afford, or our government is not funding research in those areas, can we look for sources, look for collaborators to help us to innovate, to provide, make these tools simpler, that can also address similar problems as, the bigger machines. And that's what Camera is trying to do with people like Andrew Webb around the world, building portable systems, low-cost systems, and working with also the collaborators at the University College London to also make sure that these systems can produce similar quality as the high quality. If you have a Mercedes-Benz, it's a good car. But if you have a Volkswagen, it can take you to the same location, maybe in a longer time, maybe with less comfort. So what we are trying to say is that we want to build the experts. We want experts to remain in Africa and build, the quality of research, do the research in Africa, and meet and innovate to meet the needs of Africans. So this is what we are advocating. We are looking, sometimes government funding is difficult to get, but if you have philanthropists coming in to support research work, we can begin to change from bottom. We can begin to change people who understand the dynamics of the future. Africa is going to change. The population is changing. Our governments are not recognizing these. Those of our friends that recognize this change should come in and support us within Africa to prepare the grounds for the future. That is what Camera is intending to do. Thank you.
Thanks, Godwin. Just to pick up on the point that you were making, that part of the point is to train experts in MRI. And someone has asked a question here about while you're working on the training and the education, what mechanisms are in place to avoid the brain drain challenge that you've highlighted in your talk as well?
Beautiful question. The brain drain is a major problem. But one of the mechanisms, why do people leave the country? They're leaving the country or leaving the countries for greener pastures, for better economic, packages. They are poorly paid. So one of the ways to do this thing, if we have experts that can live within Africa, the technology has made it easy for people to live within Africa and work elsewhere. If you can live in Africa and work elsewhere, you can earn. Those people who go, why are they leaving? They're leaving to go and earn better pay. Can those who are in Africa earn the same pay as they would have earned, living outside Africa? So if we can begin to increase the quality of pay of researchers, quality of pay of teachers, the quality of pay of those who are doing this job within Africa, it may help in retaining these individuals. We do not need too many people. We need few people who can train, who can be willing. The more you train, people will always leave. But if you have a critical mass staying, those critical mass can be the engine for greater change in Africa. So what we're trying to do is that let's just produce more. Let's produce more experts within the country. Let's have a training ground in Africa. Let's invite the technological giants, the GE, the Siemens, let them come and put their machines, their industries in Africa. Let the experts be here. We have the human resources. We can do it. And I think that if we are training people for the world, it will be good. The critical mass that will stay behind will continue to innovate and cause change. I see Africa as the China of tomorrow. Technology will come to Africa, the human resources, the technology will begin to work in Africa. And my plan is, or my hope is to be able to train the young people, because the young people are the leaders of tomorrow. If we train them well, if we're able to get experts to remain in Africa and work in Africa, there is a hope for Africa.
Thanks,
and then
Prof.
those who have left also, to encourage them to come back. Thank you.
Thank you. I think moving back on to human resources for health question, Laetitia, I'm just curious about whether there have been follow-up studies from the one in 2020 and whether you've measured, how many people have exited healthcare, especially since the beginning of the pandemic. And another question is, what explains the huge discrepancy in numbers between doctors in private and public hospitals? And what are the solutions for kind of bridging, trying to bridge that gap in the numbers?
Okay, sorry, the first question, Morateki, did that refer to the wisdom study?
The wisdom study, yes.
So we do a follow-up survey every year. We completed the 2021 survey at the end of December, so we don't have the, we haven't analyzed the results as yet. But I don't quite understand the exit. So just I'm sort of speaking from memory. We look at a number. I've just presented a little bit of the COVID findings because that's relevant to my talk. But we look, in essence, we tracking these professionals, and every year we ask them sort of similar questions, whether they're still in the original profession. And because it's a longitudinal study, we'll be able to see over time what are the factors that are associated with some of their decisions. So we know already, for example, that some interesting findings from the clinical associates that we're following up, that quite a sizable proportion of them are studying, have finished their training, but they're not working as clinical associates. And that's related to a large part to the way that the public health sector is structured in South Africa. And I guess like a hierarchy, which puts doctors right on top. Yes, but I think that's probably for another discussion on kind of like where some of these health professionals are after 4 or 5 years. Just to say that in South Africa, many of them have to do, so pharmacists and doctors, for example, have to do a first internship and then community service, and then nurses, OTs, physios, and dentists have to do 1 year of community service. So that's why it takes a long time, why we're following them up over a period of 15 years, because you'll only really, in the case of doctors, it's after quite a long time where you really be able to see what choices they make. So quite a large number of them, the doctors are still in the public sector, and we think it's related to specialization, because the public sector is the only place where they can specialize at this point in time. Private medical training is not allowed in South Africa. So that's just out of interest. Then the issue around the discrepancy between doctors in the public and private health sector, it's really policy decisions that were taken in prior to democracy, and of course we're still dealing with the legacy of that. So, for example, what the apartheid government did was to there was an argument that that if you encourage the growth of the private sector, then those individuals with the ability to pay would be able to go to the private health sector, and the state or the public health sector would be able to take care of the needs of the indigent population. That was one of the reasons. And so at democracy also, I think there were some strategic mistakes. So that to a large extent has accounted for the growth in the private health sector to what it is very strong and very powerful in South Africa. At democracy also, my personal view is that we made some strategic mistakes in that there was insufficient regulation of the private health sector. And there was generally if you look at many of the early policy documents, it talks about collaboration between the public and private health sector, but there wasn't any regulation to certainly contain the growth of the private health sector. And so any attempt to introduce new legislation or reforms in that way is basically met with a lot of resistance. So that accounts for. Of course, there are also doctors who work as independent practitioners in the private health sector, and there's also a phenomenon of multiple job holding, where people work in the public sector, but they spend a significant amount of time in their private practices or attached to private hospital groups.
Thanks.
It's a complex issue, and I guess I could go on about it for the whole night, but we don't have the time.
Yes, I think this is true. I think it's true of both of your talks that these are incredibly complex issues, and what your talks both have in common that they're not only focused on the health sector, but that they kind of highlight that we're facing very big challenges in the health sector in Africa. But glad that there are also conversations about solutions going forward. So with that said, I wondered whether Godwin, you would begin with giving some closing thoughts before we move on to Laetitia's closing thoughts.
Yeah, thank you very much. Just to close, I just want to thank, of course, the African Oxford Initiative for putting together this and bringing to the fore the issues in Africa, and then trying to see how we can generate ideas and to solve the problems in Africa. Also to see, I would love to see whereby people from Oxford begin to also go and also visit Africa and begin to also see things on ground and collaborate even on ground. I think that's what I would like to see going forward. Like Laetitia said, the problems are enormous, but the way to go about it is to have the will. And with Camera, what we are trying to do is to look for global partners who are willing to collaborate and go even virtually to support training programs to build people. The best legacy any nation can leave its people is education. And I think for the healthcare sector, what we can do, if we can strengthen the healthcare sector, strengthen the educational sector, we will be able to build nations that will outlive and outlast any challenge or any system. Because if you are educated, you can think. If you have the power, you can innovate, you can solve problems. So what we need to do to the next generation is to think, give them that power, that ability to be able to think, to be able to create, to be able to innovate, and then they can adapt and then change change the systems and then survive and make a better world for themselves and for those coming after them. Thank you.
Thank you, Laetitia.
Thank you very much, Moratehi. So I want to say thank you to you, David and Chimwemwe, certainly for putting this together. But I also want to say thank you to my colleagues and friends from South Africa who gave up their Friday evening to come and listen to the presentations. My take-home message, which is really that I wish that not only the government in South Africa, but governments throughout the world actually put their money where their mouth is in terms of human resources. Human resources for health are an investment, and they are also a multiplier effect on both economic growth and well-being. And so if we invest in human resources for health, then it will follow that we'll have MRI technicians. It'll follow that we'll have, leaders that are actually able to lead innovation and change in the health sector. So that's really my closing slogan: invest in human resources for health for a better tomorrow in Africa. Thank you.
Thank you.
Thank you so much. That brings us to the end of today's insaka. I would like to thank both of our brilliant speakers for the talks today, and also to thank the audience. Thanks for joining us. See you again on the 4th of March when we have our next insaka. You could check out our social media, Twitter, and visit our website for registration details. Goodbye for now, and thanks for joining.
Thank you.